Herkese merhaba.
Hello. Today I'll be talking about inborn errors of metabolism presenting with psychiatric symptoms in adolescents. How do we diagnose such patients, and what should we be careful about vis-a-vis treatment? In metabolic diseases, we see many different symptoms, neurological symptoms, other sorts of symptoms, and if the disease is severe, developmental problems and seizures might occur. If it's mild, however, only behavioral and personal disorders arise. In the psychiatric picture that is presented, from symptoms all the way to syndromes, you have all different sorts of manifestations of metabolic diseases. What is a metabolic disease? Here's a rough description. An enzyme, lack of an enzyme or disruption in the enzyme results in impaired synthesis or neurotoxic effects because of accumulation. That is the rough definition of this. So in the end, either the central nervous system functionality is impaired or the structure of the CNS is impaired. Why during adolescence? Why do we see this more? There are great structural changes during adolescence. Myelization is increased and completed. Cortical cortels and subcortical connections are developed. A neurotransmitter system also goes through a restructuring. That's why metabolic diseases may occur during adolescence. Why is this important for us as psychiatrists? We see these diseases very rarely. So why are they important? Because certain metabolic diseases, although rare, first occur through psychiatric symptoms. This is the psychiatric phase. If you can diagnose these diseases, you avoid permanent damage. You can treat the disease. In metabolic diseases, this is the most effective period. Also, in the primary metabolic disease, by treating it, you can also regulate psychiatric symptoms. CEDAL looks at metabolic diseases, and there are three categories based on the symptoms. The first group, emergencies. These are acute attacks of confusion resembling acute psychoses. The second group is chronic psychiatric symptoms arising in adolescence or adulthood, and frequent symptoms of catatonia and visual hallucinations and aggravation with treatments. The third group is late onset behavioral or personality change, and this is characterized by mild mental retardation since childhood. I have underlined some diseases. Treatments are available for these metabolic diseases. You see that the number is quite large. The diseases in the first group, urea cycle defects, homocysteine defects. I'm not going to go into each and every disease. Our time is limited, but here are some of the prominent features of these diseases, and when we should be suspicious. If an adolescent exhibits bizarre behavior, delusions, and acute psychosis, if there is nausea and throwing up that accompany this, then ammonia levels in the blood should be checked. Yet another feature is, especially in valproate use, symptoms deteriorate. And as for screening tests, ammonia levels are checked during the first checks, neuroimaging might be fine or might present findings, then it is treatable. Homocysteine remethylation defects. In all these three groups, there may be psychiatric symptoms, acute attacks. During adolescence, psychiatric symptoms might arise, mental retardation might occur, and because of that, behavioral and personality disorders might occur. This causes a psychotic picture. In adults, psychotic picture of cases resulting from surgery is apparent. We need to look at homocysteine in screening tests, and it is also treatable. Acute intermittent porphyria. This is there's a classic triad here: abdominal pain, peripheral neuropathies, and psychiatric signs. This is the most common type. Psychotic symptoms might occur only, and half of the patients have psychotic symptoms. There might be a misdiagnosis of schizophrenia, and there might be recurrent abdominal pains. In screening tests, urinary profobilinogen is used for differential diagnosis. Second group, this we see a lot, Wilson disease. Psychiatric signs are seen here. 10% of all cases, the first onset is psychiatric signs, and also 50% of them all have psychiatric symptoms on different scales, and syndromic psychiatric diagnosis can also be mimicked and also can result in mood disorders. Yet another feature is it's sensitive to neuroleptics. Progressive akinesia and rigidity might also be observed in these patients, and this also reduces the response to treatment. Niemann-Pick disease type C. This is a lysosomal depot disease. 36% of the patients encounter psychiatric signs as the first onset. It also, in the patients with a psychiatric picture, there is sensitivity to neuroleptics, and there are sudden dyskinesias. And splenomegaly aids diagnosis. 90% of the patients have this, but we need to perform ultrasound, and sometimes we overlook this during physical assessment of the patients. Metachromatic leukodystrophy, this mimics schizophrenia, and there is periventricular leukoencephalopathy, cerebral androleukodystrophy. Again, there are signs of mood disorders. GM2 gangliosidosis, treatment refractory symptoms are observed here by and large, and we have some case studies on these. Likewise, cystathione beta synthase deficiency. This also shows mental retardation plus chronic symptoms, or chronic symptoms without mental retardation. This is how the disease progresses, and this is also treatable. In the final group, mental retardation plus behavioral problems are observed in the patients. Behavioral problems, as for a screening test, blood amino acids are checked, or urine organic acids. You have the opportunity to discern that there is this condition, alpha monoacidosis and beta monoacidosis. There are systemic symptoms, auditory problems, mental retardation, and behavioral problems. This is a metabolic disease that exhibits those symptoms, creatine transporter deficiency, monoamine oxidase A efficiency, behavioral problems are seen. There are case presentations, but we lack studies on these diseases. So when should we suspect a metabolic disease? Well, of course, family history, metabolic disease history in the patient, or recessive or X-linked genetic transmission in the patient should cause us to be concerned. Also, triggering factors, the existence of triggering factors that are accompanied by psychiatric symptoms. Fever, food intake, surgery, or prolonged fasting are some of these clinical signs. Also, signs of a more diffuse clinical picture, neurological signs and systemic signs like skin problems, ophthalmological signs, or visceral signs. But of course, this is not how it always happens. Sometimes there is no patient family history or no trigger that triggers the disease, and in the physical assessment or neurological assessment everything looks okay. When that happens, all you are left with are psychiatric presentations and psychiatric signs that would give us cause for concern, and those are limited. Acute onset, fluctuating of symptoms, treatment-resistant psychosis, confusion, or visual hallucinations, single visual hallucinations, catatonia, worsening with psychiatric treatment, and abrupt onset dyskinesia with neuroleptics and mental retardation are some of these psychiatric features that should give us cause for concern about the existence of a metabolic disease in that given patient. This is a repetition. I prepared this for you. Which psychiatric medical treatments are available for which diseases, or which medical treatments cause deterioration in the diseases? Urea cycle disorders, valproate, for porphyrias, imipramine, carbamazepine in Wilson's disease, neuroleptics in GM2, TCAs in respiratory chain disorders, valproate, and in catatonia antipsychotics. This may not be easily visible, but what it says basically is this. This is like a pathway towards diagnosis. If there are atypical psychiatric signs, you need to first establish whether those are acute or chronic. And if there are acute situations, and if there are physical assessment findings, then tests should be carried out. Brain imaging, EEG, toxicologic studies, ammonemia, homocystinemia. If there are any signs, those should be checked, and then based on the result, the treatment should be initiated. If the symptoms are more chronic in nature, first of all, you need to look at more common diseases, scan other systemic diseases, and wait for a while. If those are not to be found, it is only then should you take the next step. Look at the patient's family history, triggering factors, or deterioration with treatment, if there are any such findings, and if there is no mental retardation, advanced tests should be carried out. Eye examinations, ultrasound, electrodiagnostic studies. If everything is normal, then it could be homocysteine, cerulostin, and hexaminadases. These tests should be carried out. If they're not normal, if there's an abnormality as a result of these tests, then based on that abnormality, you need to run advanced tests. If there's mental retardation, and if the eye tests or multi-system tests look okay, then urine and blood amino acids and organic acids, homocysteine, should be checked, and brain spectral MRI should be performed on the patient according to this guideline. So let's say that we have diagnosed the metabolic disease. What next? There are certain problems, as I said from the outset, in these treatment-resistant symptoms. There's ALD, there's MLD, and there is MP type C, and with the treatment that you administer, the psychiatric presentation might worsen. It's very important to be prudent about the side effects of the drugs, keep an eye on them, consult with other specialists. These are genetic diseases. You should give genetic consultation to the patient and try to catch it at this stage and try to treat it at this stage, because this is the phase where treatment is at its most effective. Keeping an eye on the side effects is very important, I said, and also a minimum effective dose approach should be adopted. That is, achieving an acceptable improvement with the least dose possible. Of course, underlying diseases are very important. That should be taken into account. And also, the effective dose, start with 1/6 or 1/8 of the expected dose. Every 3 days, titrate this up in 4 to 6 weeks. Increase up to the dosage that you want. And in the meantime, regular monitoring for side effects and response is needed. And if there is an aggravation of side effects, you should reduce the dosage. And when the side effects are relieved, then you can increase the dose back up again. This is all I